So we'll be starting with a nice guideline. So this is a topic which has lot of things which you have to memorize.
Okay.
They're very volatile, so you have to revise this topic before. So you definitely get a question on diabetes. There are many values which you have to memorize in this.
Okay.
So we'll start with the prevalence. Prevalence for GDM is 87.5%. For diabetes mellitus type 1, it is 7.5, and diabetes mellitus type 2, it is 5%.
Okay.
So in UK, type 1 is more common than type 2. Okay.
Okay.
Then preconceptional planning. So you have to explain that if the sugars are uncontrolled, there are higher risk of miscarriage, congenital malformations, stillbirth, neonatal death, and if the sugars get controlled, these risks are reduced, but they are not eliminated. So this is something which you have to tell to the patient. And if they have a higher BMI, that is BMI more than 27, you will ask them to reduce weight.
Okay.
Again, a condition where you give high dose of folic acid, 5 milligram until
Okay.
12.
3 months only, 12 weeks.
Yeah, so these are just to revise which all conditions we give high dose folic acid. So if there is a positive family history that biological father or any family member has neural tube defects,
Okay.
or previous pregnancy there was history of neural tube defects, or diabetes we have studied, anti-epileptic medications this also we have studied, and for HIV also other conditions are sickle cell disease, thalassemia, and obesity.
Okay.
Then monitoring blood glucose and ketones before pregnancy. So in the preconceptional period, you have to monitor HbA1c while she's planning for conception on monthly basis, and also offer them self blood glucose monitoring, and in case they have type 1 diabetes, so you give them ketone strips, so that in order whenever they feel unwell, they can check the ketones to rule out diabetic ketoacidosis. Okay.
Okay. Okay.
And target levels. So I've also mentioned the in UK you will get this millimole per liter only.
Okay.
Mention milligram per deciliter because we are using it and just to have an idea. Otherwise, you just have to remember millimole per liter values, and these
Okay.
values are asked. Okay.
Okay.
So preconceptional period, what should be the target value for fasting blood sugar? 5 to 7 millimole per liter. Pre-meal. Okay. The target values when somebody is planning for pregnancy, fasting should be between 5 to 7 millimole, pre-meal values between 4 to 7 millimole, and HbA1c should be less than 6.5. You also have to remember this millimole per liter value, 4.8, it should be less than 4.8 millimole per liter. Okay. So these values can be asked, and the patient can, when the pregnancy is contraindicated, if HbA1c is more than equal to 10% or more equal to 8.6 millimole per liter. So 4.8 should be the target, and approximately 8.4 if you reverse it, you can remember it like that. More than
Okay.
0.6 millimole, it is contraindicated, or more than 10%. Okay. Then antenatal care, HbA1c levels should be tested. This I've already told. You have to test it at the booking. Once they get pregnant, how do you manage them? You have to check the HbA1c at booking appointment, and then in case it comes out to be derange or the patient has pre-existing diabetes, then you also measure it in second and third trimester of the pregnancy, because you have to assess for the risks. Because
Okay.
higher HbA1c, if it is more than 6.5 or more than 48 millimole per liter, there are higher risks in the pregnancy.
Okay.
Then safety of the medication. So if they can use metformin, and metformin, it is used off label, although it is FDA category B, but in the NICE guideline they are saying that you can use it off, it is recommended for off label use.
Okay.
Otherwise, insulin is the safest which can be used, and you can use rapid acting insulin analogs like aspart or lispro, and if you have to use long acting ones, then isophane insulin or NPH is the first choice.
Okay. Actually, we start with metformin, but insulin is ideal.
You can either start with metformin or insulin, but Insulin is safest, and that too regular insulin and these rapid acting ones. Other things are off label use. Metformin can be taken, but it is taken off label. Like they have not said that it is completely safe.
Okay.
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 Then stop this. So we already know ACE inhibitors, ARBs. We, in case the patient also has concomitant hypertension or anything, they have to be stopped. Okay.
Okay.
Statins also have to be stopped. Then retinal assessment. So retinal assessment, you have to preconceptionally you have to check once. Like if the patient comes to you and she's planning for pregnancy and she's a known case of diabetes, then you have to check for the retinopathy and before the pregnancy, unless you have done it already within 6 months. And once she gets pregnant, you again have to check it at booking visit.
Okay.
Unless you have done it in last 3 months. Okay.
Okay.
And then again, in case this at booking visit retinal, there is some problem in retinal assessment, there is some retinopathy, then you check it between 16 to 20 weeks because you can operate then. Okay.
Okay.
This is 16 to 20 week assessment is only done if the booking visit is abnormal. Booking visit you have to do for everybody, all patients with diabetes. Okay.
No, like so they can get the surgery done.
Around it, in case it is very abnormal, like there is proliferative retinopathy which
Okay.
is known to worsen, because in case there is proliferative retinopathy because during labor the intraocular and intracranial pressure increases because of the
Okay.
pain,
Okay.
right?
That may
So
complicate. So even if they are okay, after they got to know, they have to wait until 20 weeks, at
yeah,
least 16 weeks to get the surgery
that,
done.
that is the safest, and only if
Okay.
required it will be done. So
Okay. Okay.
beyond that, after that we generally don't do. And second assessment is done at 28 weeks, and this is for everybody. So all patients of diabetes, they should get the retinal assessment twice, once at booking and then again at 28 weeks. 16 to 20 weeks is additional if the first booking appointment there is some problem. Okay.
Okay.
And in case there is a retinopathy which is diagnosed, then you refer them 6 months post delivery for its treatment to the
Okay.
ophthalmologist. Okay. Then
Okay.
coming over to renal assessment. Renal assessment also has to be done and in the pre-pregnancy period, and then again during the pregnancy at the first booking visit. Okay.
Okay.
So, and what all do you see? Creatinine, when will you refer to the nephrologist? If the creatinine value is more than 120 micromole per liter, or albumin creatinine ratio is more than 30 milligram per millimole, or GFR is less than 45. So these
Okay.
are the conditions when you will refer. And during pregnancy, you measure it, you do the renal assessment at the booking visit. And again, you refer to the nephrologist if the creatinine is more than 120. Albumin creatinine, this is same, is more than 30. And again, they have added another thing. Total protein excretion is more than 0.5 gram per day. Here you're not using GFR because there is hemodilution. GFR anyways increases. So it is not a reliable parameter during pregnancy.
Okay. Okay. Okay.
Okay, and in case there is nephrotic range proteinuria that is more than 5 gram per day, or albumin creatinine ratio more than 220. So at 120 you refer, and if it is more than 220 you offer them VTE prophylaxis. Okay.
Okay.
Then risk assessment. This is again very frequently asked. So what are the common risk factors if the BMI is more than 30? If previously there is a history of macrozomic baby more than 4.5 kg, there is previous history of gestational diabetes, or a family history in a first degree relative having diabetes, or high ethnic, the patient belongs to high ethnic group like Asians are considered as high ethnic group. So for all these risk factors, you offer us OGTT at 24 to 28 weeks. Okay. So if any of these risk factor is there. However, if there is previous gestational diabetes, okay, you offer OGTT twice, once at booking and then second one at 24 to 28 weeks.
Okay. When
Again,
BMI is above 27 itself, we advise them for weight loss.
yes. And BMI 30, you have to screen for diabetes,
Okay.
GDM. Okay.
Okay.
So this point is important, that for everybody, like all these risk factors like BMI more than 30, previous macrosomic baby, family history of diabetes, high ethnic group, you have to check for OGTT only at 24 to 28 weeks. If there is previous history of gestational diabetes, you have to check OGTT twice, once at booking and second one at 24 to 28 weeks.
Okay.
Okay. Then again, this is very again important recall question. So for the diagnosis of GDM, what should be the fasting blood sugar? If it is more than equal to 5.6 and it should be post meal, not pre meal. Post meal value more than equal to 7.8. Okay.
Okay.
5.6, 7.8. So you can remember it as 5, 6, 7, 8. Okay.
Yeah, yes, ma'am.
Then glycosuria detected by routine antenatal screening. If glycosuria of 2 plus or above, this I'll correct. It should be post meal. Okay. Yeah. So if glycosuria detected by routine antenatal testing, if when will you say that glycosuria is there? If it is more than 2 plus on the dipstick on one occasion or more than 1 plus on 2 or more occasions. Okay.
Okay.
And when women are diagnosed with gestational diabetes, you offer them a joint review with diabetic and the antenatal clinic within 1 week. Within 1 week, you have to refer them to a joint clinic.
Okay.
Which will include the diabetologist and also the obstetrician. Then management. So for all women, you have to refer them to dietitian and ask them to exercise. Exercise will include walking for 30 minutes after meal. This is what you'll advise. Then management, again, very, very important, very common recall question in terms of SBA and EMQs both. So if the fasting blood glucose is less than 7 millimole per liter, okay, if it is less than 7 millimole, you just offer them diet and exercise and you see, call them after 1 to 2 weeks. If with diet and exercise it is under control, you continue the same thing. If it is not under control within 1 to 2 weeks, then you offer them metformin. Okay.
If it's not controlled, okay.
Then
So
1 to
initially dietary advice.
yes. However, if the levels are more than 7, more than
Okay.
equal to 7, then you immediately start treatment with insulin with or without metformin.
Okay.
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 And if it is between 6 and 6.9 and there are other complications like macrosomia or hydramnios, again you will give insulin with or without metformin along with diet and exercise changes. Okay. Okay. This
Okay.
slide you've understood.
Yeah, yes, ma'am.
So if it is less than 7, first diet and exercise.
Okay.
Also after 1 to 2 weeks, controlled continue
If
diet
it is not controlled, like
and
over a
metformin.
period of 1 or 2 weeks, okay.
Then metformin. More than 7, directly insulin plus minus metformin along with diet and exercise.
Okay.
If
Okay.
it is between 6 and 6.9
Mm.
and the patient has complications like macrosomia and hydramnios, then again you give insulin with or without metformin along with diet and exercise. Okay.
Okay.
Then management, consider rapid acting insulin analogs, Spartan Lisro for pregnant women with diabetes. You can also give glibenclamide with
Mm.
patients with GDM with targets not achieved with metformin or who cannot tolerate metformin. So two oral hypoglycemic agents which can be used are metformin during pregnancy are metformin and glibenclamide. Okay.
Okay.
And indications of using insulin pump or continuous subcutaneous insulin infusion is are the patients who require multiple daily doses of insulin or who are not able to achieve glucose control with significant disabling hypoglycemia.
What is that CS2?
It's a insulin pump is also known as,
Continuous.
they put a
Oh, okay.
continuous
Yeah, 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 yeah. Okay, okay.
so it is the brand name of the pump that the
Okay.
insulin very commonly. Okay, then monitoring. So for type 1 and type 2 diabetes or GDM on multiple daily insulin injections, you have to do 4-point monitoring where you check fasting, pre-meal, it will be 6-point fasting, pre-meal, 1 hour post-meal and bedtime. So
Okay.
so it will be fasting after pre-meal that is fasting, then 1 hour post breakfast, then pre lunch, then 1 hour post lunch, pre dinner, 1 hour post dinner, and at bedtime.
Mm.
So this will be around 7 point because there'll be 3 meals, so 7 and 1 bedtime extra. So 7-point blood sugar monitoring is done for type 1 diabetes and type 2 diabetes or GDM who are on multiple daily injections. And 4-point monitoring where you just check fasting and 1 hour post meal. So that will be fasting, 1 hour post breakfast, 1 hour post lunch, 1 hour post dinner. So total 4 times, right? Is done
Fasting, 1 hour post meal. How 4 times?
because there'll be 3 meals after breakfast, after lunch, after dinner.
Okay. Mm.
Okay.
Okay. There is no bedtime here.
There is no bedtime. This is done for type 2 diabetes mellitus and GDM,
Okay.
managing the diabetes with diet and exercise alone, or taking oral therapy or single dose intermediate acting or long acting insulin.
Okay.
So otherwise, in most of the cases, you have to do 7-point. Only in these cases who are either managed just on diet and exercise or taking just oral treatment or single dose insulin.
Okay.
In those patients, you can do 4-point. Okay. Then, what should be the target? So these are the targets once the patient is on insulin.
Mm.
So then, what should be the target? Fasting should be 5.3. 1 hour should be 7.8 millimole per liter. 2 hours should be 6.4. Okay.
Okay.
And it should not go below 4 millimole per liter, and during labor the sugar level should be maintained between 4 to 7 millimole per liter. So these targets also have been asked, so you have to remember.
Okay. 4 is considered the lowest.
If it is going below, that means the sugar are going below, you have to stop the insulin and give dextrose.
Okay.
Okay. Then ketone testing and diabetic ketoacidosis. Again, you have to give them ketone strips and you have to tell them to check for ketone levels whenever they are feeling the sugars are very high or they feel unwell.
Mm.
Okay, and if there is suspected ketoacidosis, you have to admit them in level 2 critical care. Okay.
Okay.
Then antenatal care, how do you manage these patients? You have to do it at 20 weeks. You have to do an anomaly scan, which will include a cardiac scan as well.
Okay.
Then you have to do a regular 4 weekly growth monitoring from 28 weeks. Okay.
Okay.
And then how frequently will you call these patients? You have to call them every 1 to 2 weeks throughout the pregnancy for blood glucose control and assessment.
Okay.
Then preterm labor with diabetes. In case there is a patient comes in preterm labor, so these beta mimetics and all, which
Mm.
are used as tocolysis, they can cause rise in the blood sugar. Even steroids cause rise in the blood sugar. So all they are not a contraindication and for using these, but in case you are giving steroids, you have to give an additional dose, and usually you have to add 25 to 40% increase in the dose is required of for insulin. Okay.
Okay. Mm.
So you, if the patient is taking steroids, if you're giving dexamethasone for lung maturity, you have to, for the time, for those 48 hours, you have to increase the insulin dose by 25 to 40%.
Does it interfere with insulin?
Ste- uh, Steroids, no, steroids will increase the blood sugar. So
Okay. Okay. Mm.
increase the blood sugar, so that's why we are increasing the dose of insulin. And also beta mimetics, they also increase the blood sugars, so
Okay.
they should also be avoided as tocolysis. So if you have to use, you use calcium channel blockers like nifedipine, depin and all. You avoid beta blockers like ritordine, isoxsuprine, which we generally use. The-
Okay.
those should be avoided as for tocolysis. Okay.
Okay.
Then timing for birth, again a very important question. For type 1 and type 2 diabetes, you have to deliver between 37 to 38 weeks of pregnancy. And in case there are maternal or fetal complications, then you plan for delivery before 37 weeks. Okay. And in case there is GDM, you deliver you plan for delivery before at or before 40 plus 6 weeks. You don't go beyond that.
Okay.
Then anesthesia for women with diabetes and comorbidities such as obesity or autonomic neuropathy, you have to send them at 36 weeks. You generally send them for anesthetic assessment. And once they are in labor or you're giving general anesthesia, you have to monitor. This is again one of the question. You will monitor blood glucose every 30 minutes from induction of general anesthesia until the baby is born and the woman is fully conscious.
Okay.
You have, because you also, in case the patient is using pump, you generally remove the pump.
She may go for hypoglycemia.
NPO also, so you have to monitor the blood sugar every 30 minutes. Then during labor and birth, I told you how much sugar should you maintain, blood sugar, what should be the target?
During
Labor and birth.
Target level should be,
while the patient is in labor, your target should be, how much should you maintain? It should be between 4 to 7.
4 to 7.
It should be between
4 is the lowest.
And in case it falls below that, then you have to give a combination of insulin dextrose combination. Okay. Especially in type 1 diabetes, and that's what I told you, insulin dextrose, if the levels are not maintained between 4 and 7 millimeter. Okay. Then neonatal care. So carry out the blood glucose testing for the babies.
If it is above 7, insulin only, no?
Then only insulin, yes. So neonatal care, carry out blood glucose routinely at 2 to 4 hours after birth. In babies who are born whose mother has been diabetic, because they are at risk of developing hypoglycemia basically. Because insulin also passes from mother to the baby, and because of the high insulin, there are chances that the baby after birth, if the baby is kept NPO, baby can develop hypoglycemia. So you have to carry out blood tests for the babies to look for other complications like polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia. All these are very common. And also you have to do an ECG for the women with for the babies of the women with diabetes if they show any because there is risk of congenital heart disease. Okay. And cardiomyopathy, you have to look for cardiac murmur.
Okay.
And then in order to prevent neonatal hypoglycemia, you should ask the patient that they should feed their babies as soon as possible. Again, a question. They should feed the baby as soon as possible, ideally within 30 minutes, and then at frequent intervals every 2 to 3 hours until the feeding maintains their pre-feed capillary glucose. For the baby, the target is, it should be at least 2 millimole per liter. Okay. Yes, if it is less than that, then you have to give them tube feeding or IV dextrose.
Oh, okay. So this target of 2 is a pre-feed.
Yeah.
Okay.
So use additional measures such as tube feeding or IV dextrose if the blood glucose of the baby is pre-feed glucose is less than 2 on 2 consecutive readings despite maximal support for feeding, or there are abnormal clinical signs, or the baby will not effectively feed orally. So in those cases you have to give them tube feeding or IV dextrose. For the babies with clinical signs of hypoglycemia, test blood glucose levels and provide IV dextrose as soon as possible.
Okay.
Then postnatal care. So postnatal also, these patients are who develop gestational diabetes during pregnancy. There is a chance that 50% of these will develop type 2 diabetes in the next 5 years. So you have to monitor them in future as well.
Okay.
So how do you monitor them? So first you will check for this fasting blood glucose. Okay. So, like if they are born, when will you check it? 6 to 13 weeks after birth.
Mm.
Again, a question. So you have to check for at 6 to 13 weeks. You have to check for fasting blood glucose. If
Mm.
it was missed, then after 13 weeks, you generally use HbA1c test. Okay.
Okay. Mm.
And 17 gram OGTT is generally not used. So the best test is you between 6 to 13 weeks you are doing fasting blood sugars. In case it is missed after 13 weeks you do HbA1C.
HbA1c.
Okay.
Oh, okay, ma'am.
So these targets again very important.
Mm.
So what should be the target when you are checking at 6 to 13 weeks? What should you see? How much should be the fasting? So ideally the fasting should be less than 6 millimole per liter.
Okay.
Okay, so this in these cases there is low probability of developing diabetes, and you offer them annual monitoring. So you
Mm.
don't keep them because again there is high chance, there is around 50% chance that they'll develop diabetes. So you'll not leave them. You'll do annual monitoring after that.
Okay.
And if the fasting is between 6 to 6.9, then there is high risk for them for developing diabetes. So you offer them advice and guidance for preventing type 2 diabetes. So you'll offer them diet and exercise
Okay.
between 6 to 6.9. And more than 7, it is frank diabetes. So you have to treat those patients.
Okay.
So
They
that,
have to, okay, start with treatment.
yes. Similarly, like if it is missed between 6 to 13 weeks, you were doing HbA1c. So
Okay.
HbA1c ideally should be less than 5.7. So if it is
Okay.
less than 5.7, there is low risk. So there is low risk, so you have to offer them annual monitoring now. From now,
Okay.
like the same thing like you were doing in fasting blood sugar. 5.7 to 6.4, there is
Okay.
high risk, and you have to offer them diet and exercise for
Okay.
preventing type 2 diabetes mellitus. And
Mm.
more than equal to 6.4.
Mm. They have diabetes.
Yes. Okay.
Okay.
This is again very important. Then this is a timetable for antenatal appointments. So this we have already done, just revision of what we have read. So at the booking appointment, you have to check for retinal assessment and renal assessment if it was not done in the last 3 months. Okay. You have
Okay.
to do an HbA1c level to establish how much risk is there for the baby. If it is more than 10, you will ask for termination, or if she comes before pregnancy, you ask for advice against pregnancy and give them contraception. And then you offer them self monitoring of blood glucose or 75 gram 2 hour OGTT as soon as possible in patients who have history of previous history of gestational diabetes. So
Okay.
OGTT should be offered at booking and at 24 to 28 weeks if there is previous history of GDM.
Okay.
So then the risk of developing GDM in this pregnancy is very high. Okay.
Okay.
Then
So
vitamin.
only in cases of previous history.
Yes.
Otherwise, no need OGTT.
Otherwise, only for the risk factors which I told you.
Mm.
If the BMI is more than 30,
Okay.
family
Okay.
history, high ethnic group, previous macrosomic baby, these four
Okay.
are there. Then you check between 24 to 28 weeks OGTT.
Okay. Otherwise, we do only fasting PP or HbA1c.
According to this the guidelines, that is
Okay.
also not recommended in case these risk factors are not there. You don't do screening for everybody.
Okay. Mm.
Yeah. Then visits, you have to call them every 1 to 2 weeks throughout the pregnancy in joint diabetes and antenatal clinic.
Mm.
Then at 16 to 20 weeks, you have to do an additional retinal assessment if the previous one was abnormal.
Mm. Okay.
Okay, 20 weeks, you have to do a detailed anomaly scan, which will include the scanning for the heart as well, because there is
Okay.
risk of congenital heart disease. Then 28 weeks, again, for everybody, you'll be doing a retinal screening.
Okay.
And then from 28 weeks, I told you every 4 weekly, you have to do a growth scan and look for liker. So 28 to 36 weeks. So 28, 20, 32, 36.
Mm.
Yes. For growth and amniotic fluid. 36 weeks, you have to discuss about the time, mode, management of birth, and for the anesthetic, if you have to get a review, you'll get it done.
Okay. This retinal assessment, when we do during 16 to 20 weeks, If they found to have any complication, they can undergo surgery, right?
Yes, they can treat. Yes, if
Like
it's there
then
and
so it
they think that it can hamper with the labor
okay.
and pregnancy, then they can treat. Yes.
Okay. Again at 28 weeks, they have to come for review.
Yes, that is for
Just to
everybody. All patients
okay.
with diabetes. You have to do at booking as well as at 28.
Okay. So retina is assessed at 20 weeks as well as at 28 weeks.
Yes.
Okay.
Is assessed at booking and at 28 weeks. Yes.
Okay.
Okay. Then and renal assessment only at booking.
Okay.
Okay, then 36 to 37 to 38 weeks, you plan for delivery for type 1 to type 2 diabetes. And 38 weeks, again, you offer test for fetal well-being. And for GDM, the birth should not be delayed beyond 40 plus 6 weeks.
Okay.
Then next topic, management of diabetic ketoacidosis in pregnancy.
Mm.
So diabetic ketoacidosis, it can occur, mostly it is observed with type 1 diabetes, but it can also occur in patients with type 2 diabetes and gestational diabetes. Why it occurs? Because there is, in these patients, there is relative or absolute insulin deficiency. And plus, with pregnancy, there are increased counter-regulatory hormones, like there is increased cortisol, catecholamines, glucagon, growth hormone. These causes significant changes in the metabolism, such as lipolysis and proteolysis, which
Mm.
increase gluconeogenesis and together with glycogenolysis, which result in excessive hyperglycemia. This is accompanied by decrease in the glucose uptake in the peripheral tissues, and lipolysis provides excessive fatty acids to the liver, enhancing the process of ketogenesis and
Okay.
resulting in ketoacidosis. Okay.
Yes, ma'am.
Then, what are the risk factors for developing diabetic ketoacidosis during pregnancy? In any kind of stress can increase the
Mm.
blood sugars and can exacerbate, which can be because of protracted vomiting or
What
hyperemesis
is
gravidarum, because there'll be dehydration. Okay, any kind of infections again.
What is
If
protracted vomiting?
the vomiting which is not controlled,
Okay.
okay, then
Okay.
infections, or the patient is not taking insulin properly,
Mm.
or if the patient is taking medications which precipitate diabetic ketoacidosis like beta mimetics
Okay.
or uh, um, steroids.
Okay.
Then there is insulin pump failure. It has failed and the patient doesn't know it is not acting. Okay.
Okay.
The patient has gastroparesis, like the stomach is not moving properly and the sugars are getting more and more
Okay.
absorbed.
Mm-mm.
Okay. Then medications precipitating diabetic ketoacidosis, beta mimetics, also steroids. Okay.
Okay. Mm.
Then what are the clinical presentation? How will the patient present? Patient presents with nausea, vomiting, abdominal pain, polyuria, polydipsia, blurred vision, muscle weakness, drowsiness, lethargy, changes in mental status, hyperventilation, which is also called as Kussmaul's breathing. There is a characteristic smell, teardrop odor, and there's dyspnea, hypotension, tachycardia, coma, shock, and abnormal fetal heart rate racing.
Okay.
These are the symptoms. And what type of, again, a recall question, what type of ketoacidosis it is? It is high anion gap metabolic acidosis. So high anion gap. So the anion gap here is more than 12 for
Okay.
the diagnosis, and it is metabolic. Metabolic means bicarbonate levels are low. Metabolic acidosis means bicarbonate is low. So bicarbonate is low, and acidosis, that means the pH is low. Okay.
Okay. Mm.
Other features, obviously, it is ketoacidosis. So serum and urine ketones are more, sugars are high, bicarbonate is low, pH is low, anion gap is more. There is high base deficit of more than equal to 4, and potassium may be falsely normal or elevated. Okay.
Usually in pregnancy there will be respiratory acidosis. Mm.
Nausea with this pregnancy, there can be respiratory acidosis. Yes.
Here there is a metabolic acidosis. Okay.
pregnancy, because of decreased lung capacity, respiratory acidosis can occur mild.
It's a physiological, no, if there is respiratory acidosis.
Then diagnosis, these values you can like misremembering, but this for diagnostic values you have to remember. So for this diagnostic criteria is blood ketone levels more than equal to 3 millimole per liter, or urine ketones more than equal to 2 plus, blood glucose more than 11 millimole per liter, or a known case of diabetes, bicarbonate level less than 15, and or venous pH less than 7.3. So
To
these
diagnose okay, ketosis.
diagnosis. Okay.
Okay.
Then how will you manage these patients? These should be managed in level 2 critical care, which include HDO or ICU. Okay.
Okay.
Eclampsia patients have to be managed in level 2 critical care.
Mm.
Severe eclampsia patient. Okay, so these are two conditions. This is again one of the question in the recalls where what level of care will you give? So it will be level 2 critical care.
Okay.
Okay, then you have to give them fluids, IV fluid therapy, IV insulin, electrolytes you'll correct. Uh, Assess if there is a need of bicarbonate. Usually, bicarbonate is avoided as far as possible unless it is required. The levels are very low. And you identify and treat any precipitating factors, like if there is any infection, you'll treat that. If there is any hyperemesis gravidarum, you'll give antiemetics and treat that. Okay.
Okay.
If there is any precipitating drug, you'll stop that.
Mm.
Insulin pump failure, you'll check. Then monitoring for maternal and fetal responses. Then fluids. How do you give the fluids? You have to give what fluid you will give. So you give this normal saline you give, isotope normal saline 0.9%. How much will you give? So dose also they have given 10 to 15 ml per kg per hour in the first hour, and then according to the hemodynamic status. So
Okay.
usually you give 1 liter per hour for the first hour, 500 ml per hour for the next 4 hours, 250 ml per hour for the next 8 hours, and then 150 ml per hour.
Okay.
Okay. And when the blood glucose falls below 14 millimole per liter, which is equivalent to 250 milligram per deciliter, then you add dextrose in the fluid. With
Why
normal.
it may reduce further?
Because what happens, insulin, if you're if you're just giving insulin alone, it
Okay.
causes the potassium to move inside the cells and causes hypokalemia. So you
Okay.
have to add dextrose. Okay.
Okay. Will it not increase further then?
No,
Increase
but
the.
you're also giving insulin, no?
Okay.
You
Okay.
give,
Okay.
yeah. So you give insulin dextrose in
Insulin
combination.
causes hypokalemia.
Insulin causes hypokalemia, yes.
Yes,
Okay.
please.
And you will do a strict input output, and the urine output should be at least 0.5 ml per kg per hour.
Okay.
Then a potassium replacement. So for because I told you insulin, it causes the potassium to decrease. It causes the potassium to move inside the cells. So you first check the potassium levels. If the potassium levels are very low, less than 0.3, then you do not give insulin. You first correct the potassium.
Okay.
Okay. And for potassium correction, urine output should be adequate, because if it is
Okay.
less, potassium toxicity can also occur. It directly affects the heart. So,
Okay.
on how much potassium should be there? And for this output maintenance, you have to give an IV fluid bolus first.
Okay.
Then how much potassium will you give? You'll give 40 millimole per liter of the ongoing IV fluid. If the potassium level is less than 3.5, consider medical staff review and switch to IV insulin with potassium once the potassium gets corrected. So first you correct potassium and then you give insulin. Okay.
Okay.
And if the potassium is more than 5.5, then you don't give potassium, you give only insulin. And how much insulin do you give? You give at a fixed rate, zero point 0.1 units per kg per hour. And then finally you increase to maximum 1 unit per hour, increase to 1 unit per hour. If
Okay.
specific targets are not achieved. So like first you start with zero point 0.1 unit per kg per hour. So if it's a 70 kg person, you'll start at 7 unit per hour. Then
Okay.
you check for the targets. If the targets are not achieved, you increase by 1 unit per hour every hour. Okay.
Okay.
And once the targets are achieved, you have to stop the insulin. And when do you stop it? It after 30 to 60 minutes from the first dose of subcutaneous rapid acting insulin and administered with the meal. Okay,
Okay.
so you give this is the infusion that you are giving. So you stop the
Okay.
infusion 1 hour after you have given the regular dose of insulin. 1 hour after that.
Oh, after starting this only, we are stopping the
The regular.
infusion itself.
Yes, because it will also take
Okay.
some time to act, So
Okay.
1 hour
Okay.
after,
Okay.
30 to 60 minutes after that you start. And if
Okay.
the potassium level is between 3.3 to 5.5, you have to give potassium as well as insulin. Doses
Okay.
are the same.
So that it doesn't reduce.
Yes.
Okay.
So less than 3.3, first potassium and then insulin. 3.3 to 5.5, both potassium and insulin. More than 5.5, you need not give potassium, you give only insulin.
Mm.
Okay. And these targets again you have to memorize. So target should be ketone levels should decrease by 0.5 millimole per liter per hour.
Mm.
Bicarbonate level should increase by 3 millimole per liter per hour, and blood
Okay.
glucose should decrease by 3 millimole per liter per hour. So
Okay.
this is from the when you started treatment. So these
Okay.
target. So 0.533 you remember.
Okay, ma'am.
Then identify and treat the cause by taking the history, do the investigations like CBC, urine analysis, culture to rule out infections, and then patient monitoring. This is again very important. So you have to monitor once you are treating the patient, you have to monitor the blood glucose hourly. Every hour you have to monitor until the patient is stable. Blood
Mm.
tones again have to be monitored initially hourly and
Mm.
then every 2 hourly,
Okay.
and serum electrolytes, blood urea, nitrogen, creatinine, venous pH every 2 hourly until the patient is stable.
Okay.
Then you have to check for fetal well-being. You do a scan, do CTG, ultrasound if indicated, and delivery if indicated.
Okay.
Then resolution criteria. When will you say the patient has recovered completely from diabetic ketoacidosis? If the ketone level falls to less than 0.6 millimole per liter, pH
Mm.
becomes more than 7.3 and bicarbonate more than 15.
Mm.
However, after 6 hours of decay, bicarbonate is not a reliable indicator. Okay.
After 6 hours of decay.
Uh, yes, because what happens, you're giving so much fluid, no?
Okay. Okay. Mm.
Bicarbonate levels will change. Like they combine
Okay.
with the water and form this HCl and all.
Okay.
Three will combine with water, no? Will form uh, it'll react with it, and this value will not be very reliable because you've given so much of IV fluid, and there'll be hemodilution also.
This is when a patient is on treatment.
Mm. Then
When
normal.
he is on treatment for decay. Mm.
Yes, this is post treatment to define the patient has completely resolved, and you can plan for
But the
discharge.
preconception level, when it goes below 15, when it
It should be.
goes below, that we
It
are
should be.
checking during diagnosis.
That is for the diagnosis. Ideally,
That
it
time
should be
we
more
give
than
them
15.
sodium bicarbonate when it is less than 15.
Yes.
Okay.
Okay. And anion gap should normalize. So these are the values which are opposite of the diagnostic values. Okay.
Okay. Mm.
Excuse me. Then insulin pumps in pregnancy. Just a second. So insulin pump, these are also called as CS2 or continuous subcutaneous insulin CS. It is actually CSII, continuous subcutaneous insulin infusion pump. Okay.
Okay.
These are mostly used for type 1 diabetes, but they can also be used for type 2.
Okay.
And 6% of the UK individuals they use pump.
Mm.
This is important. This has been asked. So
Mm.
these are filled with rapid acting insulin only.
Okay.
So as part, you cannot use regular insulin in these pump or long acting in this pump. Okay.
Okay.
and they have they are said to give some basal dose according to the patient, and once the sugar rise you can give some boluses also. Okay.
What basal background dose?
So some basal dose they continuously give.
Okay.
Okay, and during the meal time the patient has to put on the push on there is a push button, so the
Okay.
patient presses, which gives a larger bolus dose.
Okay.
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 And where the site of application is abdominal wall most commonly.
Mm.
However, in pregnancy, since the abdomen distends, so in
Mm.
pregnant patients, upper thigh or upper outer buttock area is preferred.
For this infusion.
Yes, for
Is
the
it not?
infusion pump. Where have you? It is a small device which has to be placed.
Oh, okay, okay. Like there will be
There.
sensor in it. Okay. Sticking like a patch.
Yes.
Okay.
Then the benefits, it's a rapid, flexible, precise dosing can be given. It
Mm.
decreases the hypoglycemic attacks, easily programmable and quick to adapt. It is
Mm.
useful in patients with hyperemesis gravidarum who require multiple daily injections, who take
Mhm.
erratic meals or skip meals.
Okay.
It avoids multiple daily injections. Uh, However, the catheter has to be changed every 2 to 3 days. It
Okay.
avoids nighttime hypoglycemia, dawn phenomena.
Mm.
Uh, Dawn phenomena is requirement of higher dose early morning hyperglycemia is also called as dawn phenomena.
Okay.
Insulin peaks in the insulin level drops and sugar peaks in the morning. So
Mm.
in the morning, some people the sugars come out to be high, so
Mm.
they require higher morning dose. So that is called as dawn phenomena.
So
This
advantage of using this pump, it will adjust by reading the values, or we are adjusting the
Why
dosage.
give injections? No, it'll it's a subcutaneous inserted and the bolus is released directly. So there is no pain
Okay.
of the injections. So multiple
Yeah, but only we are adjusting the dosage.
we can adjust the dose, yes.
Okay, seeing the values. Mm.
Then disadvantage, it is costly,
Mm.
greater education and clinical support is required.
Mm.
Potential decay if accidentally it gets removed or it malfunctions.
Mm.
Sometimes there can be the pump site infection
Okay.
can be there, and if there is poor compliance, then there can be difficulties.
Okay.
Then insulin dosage and pregnancy. So in the pregnancy, usually early part of the pregnancy,
Mm.
the basal rates, the insulin levels, they increase by 50%.
Mm.
Okay, so in the initial part of the pregnancy, the patient requires lower dose of insulin. However,
Mm.
later part, in after 28 weeks mostly, that's why we check it between 24 to 28 weeks, there is insulin resistance which occurs and the dose requirement increases. Okay.
Initially, during 8 to 16 weeks, it is reduced.
Basal requirement is less. So
Okay, okay,
ins-
okay, okay. So increased 50% thereafter. Okay, there is a demand. Mm.
and there is reduction in carbohydrate insulin ratio by fourfold after 16 weeks, so higher dose is required, and also gdm risk is also more after 16 weeks, so that's why we are doing ogtt around 24 to 28 weeks where the risks are the maximum.
Okay. Mm.
Intrapartum and postpartum. Intrapartum because the patient is mostly fasting, so
Mm.
you need to decrease the dose, and postpartum because the patient returns to the normal pre-pregnancy value. So
Mm.
usually the you need to decrease the dose once the
Okay.
patient.
Mm.
Then these are the two recall questions. So this was a scenario. The patient was 8 week period of gestation. She was not on any medications. Known case of type 2 diabetes mellitus.
Mm.
She developed drowsiness.
Mm.
What would be the treatment?
Known case of diabetes, but she is not on medication.
Hmm.
So what, she went hypoglycemic?
Because 8 to 16 weeks, I told no insulin requirement decrease. No, it should be on. She was on medications, and she developed drowsiness. So
Okay, so hypoglycemic.
because 8 to 16 weeks, the requirement decreases.
Okay, okay. So
Okay.
she's on medication. Okay.
And then next question, minimum duration from commencing a pump to her starting to try pregnancy. So once you put a pump, and then when should you, what advice will you give when she can plan for pregnancy? So
What it is, ma'am? I don't get it.
so in the pre-pregnancy period, if you put the pump, because
Okay.
it take time for the pump, like for the
Yeah,
dose.
you said it will take an hour, 1 hour.
No, that's okay. But to adapt to it, the patient to learn how to how
Okay.
it functions and all, and to calculate the doses, how much push she has to push, press on the push
Okay.
button to release. What should
Okay.
be the doses? All that calibration, it will take some time.
It
So,
will take 3 months for
so,
her to adapt to it.
so it is advisable that she can start trying for pregnancy 3 months after the pump has been inserted.
Okay, okay, okay. This is in preconception period.
In the preconception period, this was again one of the recall
Yeah,
questions.
okay, okay, okay.
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 So this was all about the
And
diet.
over diabetes is diabetes prior to pregnancy.
The
Since
over diabetes is anyways diabetes 1 or 2 is
patient,
not diabetes.
a pregnant female is found to be diabetic.
If it is not diagnosed for the first time in the pregnancy, it is over diabetes. If she already has
If so, she's already on
medications, on even
medication.
if she's not on medication but already diagnosed, so
It's
she's
like a chronic hypertension.
yes.
Okay. And what is the treatment for migraine, ma'am?
Treatment for migraine.
Mm.
So migraine, it'll in like there are these triptans which can be given if the migraine is severe. Otherwise,
Mm.
you usually give simple painkillers like NSAIDs are usually avoided. Uh,
Okay.
can be given after 28 weeks if the pain is severe.
Mm.
Uh, Otherwise, you give Dolo 650 paracetamol and all.
That's it.
And
Flunarizine is not safer.
to avoid the triggers, because there are some, for most of the patients, they have some triggers. Like for some people, it is light, some people, it is sound. So you
Mm.
particularly ask them to avoid the triggers.
Flunarizine is also not safer.
Hmm?
Flunarizine.
Narizine is not safe.
And
Triptans,
how do we give her?
they are also like category C.
Mm.
The initially you would ask them just to try avoid the triggers and take Dolo 650. If it is not getting relief, you can give triptans.
Can we give paracetamol infusion?
Yes, paracetamol is safe.
Okay, infusion. Okay. And how do we give a rectal diazepam? Is it suppository or
Yeah,
injection form?
it's a suppository.
Oh,
Like
it comes as suppository only. Okay. Okay, ma'am.
thank you.
Okay, ma'am. Thank you, ma'am. Good night.
Good night.